Bipolar and Related Disorders, Chapter 13. These are the terms you're going to want to be familiar with from this chapter, from anticonvulsants to tangential speaking. So the first set of objectives we're going to talk about is your ability to be able to recognize signs and symptoms of bipolar 1 versus bipolar 2 versus cyclothymic disorder, and distinguish between mania and hypomania. So let's get into the three types of disorders we're going to be looking at. First off, bipolar 1 is your most severe of your bipolar disorders, okay? And it has the highest mortality rate, meaning the most likelihood that someone will pass away, die. And this is because of the extreme mood swings that are going to occur and the likelihood this person will put themselves at risk with at-risk behaviors and endanger their lives, that it results in death. Okay, so when we say at-risk behaviors and mood swings, what we are talking about is that this person is going to go from a manic level of all the way to euphoria and feeling like they are God, that they are invincible, that they are greater than the universe, okay, to deep, deep, deep depression to the lowest levels possible, and even think lower than that. So they go from the one extreme to the other extreme. And when you know how high it can be to be God and then go to the ends and the depths of the earth to know despair beyond despair, that is extremely severe. And to be diagnosed with this, you have to have at least one manic episode. So you can be in a depressed state and have bipolar 1. You can be in a manic state and be bipolar 1. But you have to have that extreme state. Now in bipolar 2, we don't necessarily have that extreme levels. We have at least one hypomanic episode and at least one major depressive episode. So we still have the depressive state, but instead of going into a manic phase of where it's necessarily in euphoria, the patient goes into a hypomanic state. So what is hypomania? Hypomania is where a patient gets the high energy. However, they cannot get to that euphoric level. So they have this high energy, but they're cranky. They're irritable. They cannot be satisfied. So high energy, but can't get satisfied. So they're cranky. They're irritable. Okay, makes sense? But they don't have the extreme swings. They can go very low, but they don't go extremely high. They're still at risk for suicide. Those risks are all still there, but just not as extreme. Now, cyclothymic means that a person has mild to moderate symptoms of depression, and that they have gone on for at least 2 years, and they could possibly have some rapid cycling. So they get where they can get to normal, then they get depressed again. Get to normal, get depressed again. So they cycle, okay? So we have some other bipolar disorders where we have substance medication-induced bipolar or related disorders. One of them can be steroids. Steroids can induce a manic state, okay? We also have other bipolar-related disorders due to medical conditions. And we also have specific bipolar-related, unspecified bipolar-related. So let's get into what a manic behaviors look like. I just kind of had hinted towards them, but I want to make sure you kind of see what we're talking about. We're talking about extreme drive and energy, okay? Now, what will happen at a certain point when we have extreme drive and energy? We will not finish projects and tasks that start. We'll get started on them and we'll start many of them, but typically what will happen at a certain point is the person's not able to complete them because they'll start in on another project, on another task. There's an inflated sense of self-importance. That term is called grandiose or grandiosity. Okay? And it can get so severe they believe they are Jesus Christ, that they are God, that they are famous, even when they are not. That self-importance gets so large that that sense is so strong and so driven in them, it gets way exaggerated and way inflated. There's drastic reductions in need to sleep. They don't need it. There is no REM cycle. And the more, or the lack of sleep, the lack of REM cycle just intensifies the mania even further and increases the risk for that psychosis to occur. There is excessive talking with pressured speech. There's a personal feelings of racing thoughts. Their thoughts go much faster than they can speak. They have all sorts of ideas and that are going through their minds. They're distracted by environmental events, and every little movement, motion, stimuli gets them jumping and stimulated even further. They're obsessed with and over-focused on all sorts of goals and activities. There is lots of purposeless arousal and movement. So they're constant in motion without a true sense of real purpose behind their movement. So we get up and we turn the lights on, we turn them off, we turn them on, we turn them off. We move the paper from here to there to there to there to everywhere without really having a true purpose for what we're really doing this for. And there's lots of dangerous activity, such as spending money. Let's go ahead and buy 5 Cadillacs today. There's not a need for it. We're just doing it. Reckless sexual encounters. No prevention measures in place. So we contract STDs. We get pregnant. We do risky investments. We'll use substances, drugs, just to do it. And we'll go off with strangers we don't know just to go off with them and end up human trafficking, doing things that the person would normally not do. They're in a marital relationship, committed, and they love their spouse, but then go have a sexual encounter with a stranger just because. There isn't any real thought except for that they're highly sexualized right now and they need to just do it. And they destroy their marriage. Let's just drive the car off the bridge. Now remember, when a person's in this manic phase, they don't have control over themselves. It's impulsive. It's without thought. It requires lots of redirection. When the person starts to come out of the manic phase, they're pretty much fully aware of what they've done. And they have to come back and face their spouse, their family, the community that they're in. Whether that's they stripped off all their clothes and ran in the hallway naked. They sexually propositioned everybody that's in the room that they have to face. So you can just imagine what their self-esteem is going to be like. And this is the moment they're at greatest risk for suicide. So euphoric, feeling wonderful in the beginning, and then it turns into a very scary, dark, as it progresses towards a loss of control and confusion. So it really feels great to feel this grandness. But as it climbs and goes higher and higher, it gets very dark. It gets very out of control. It gets very confusing. And then when you go to the other end of the depression, you get dysphoric. And it's a mixed state of depression and depressive symptoms along with mania. So euphoric is this wonderful high that you initially feel, and then it gets dark and depressive symptoms can come in and you become dysphoric with mania. So you have all this energy with this darkness and agitation. Suicide is not far behind. So bipolar 1, you at least for 1 week have mania, excessive activity and energy, alternating mood of depression and sometimes mixed with agitation and depression. Sometimes you're actually free of symptoms. And the biggest issues we see is you have problems maintaining social connections and employment. Can you imagine trying to maintain a relationship? Who's going to stay with you when you behave like this? What friends are going to stay with you? What boyfriend? What girlfriend? How many family members? It's not uncommon to see psychosis in the form of hallucinations, delusions, and disturbed thoughts. 21% of the patients, primary care physicians diagnose a patient with major depression and don't realize the patient is actually bipolar. And so they start treating them with an antidepressant, not realizing they have a completely unstabilized mood. And they treat the depression and then they run into a manic phase. Mortality again is very high. In bipolar 1, we see risk for suicide attempts between 25 to 60% chance that there's going to be a suicide. 25 to 60%. Now in bipolar 2, we have a lower level of mania. It alternates with that profound depression. And that lower level symptom is called hypomania. They're still going to have that excessive energy, and it's going to last for at least 4 days, and it involves symptoms of mania, but it's going to be more of that irritability. That energy is going to be there, that goal stuff is going to be there, but it's just not going to have that euphoria. And we don't see psychosis with the mania, okay? But we're going to see it more on the depressive side. And we usually don't see relationships and work being as impaired as we do in bipolar 1. But when they're on the depressed side, that risk for suicide is there. So in cyclomania, sometimes we do see some hypomania there, alternated with some mild to moderate depression. And this may be going on for a couple years in an adult, and in children 1 year. It will cause some social and work impairments. And we usually tend to see that irritable hypomania episodes. In children, we see irritability and sleep disturbances in cyclomania. And yes, bipolar 1 and bipolar 2 we do see in children and adolescents. And a lot of times we'll hear children and adolescents being diagnosed with ADHD before we hear a diagnosis of bipolar. Now you'll also hear a term called rapid cycling. And what rapid cycling means is that we're seeing a patient having these mood shifts. And in order to get a diagnosis of rapid cycling, they have at least had to have 4 mood shifts in a year. Sometimes we actually see these mood shifts happen even faster. They can do a mood shift from mania to depressed within hours or days or months. The more frequent those mood shifts happen, so if they're happening within hours, it's much more difficult to get a patient stabilized, get that mood stabilized and in control. They have a poor level of functioning, and they have a higher risk and resistance to conventional treatment. So, what we know is that 5.1% of bipolar patients have a lifetime illness. We're not able, where they can get back to a stable state and not have a reoccurrence. Bipolar 1 is more common in males, where bipolar 2 is more common in females. And cyclothymia is more common or usually occurs and begins in adolescence and in early adulthood. So what we do know is that with bipolar, it is 80 to 90% inherited, genetically oriented. Of course, we also know that neurobiology, stress, plays a big part, that chemical neurotransmitters and hormones all play in. We also know that the hypothalamus and the pituitary and the thyroid all play into the rapid cycling element with the neuroendocrine elements. We know stress may cause the imbalance that can trigger the events. And we also have another interesting factor under the environmental factors. Those who have higher education levels have a higher rate of occurrence of this disorder. So social, economic, higher education seems to have a higher incidence of bipolar disorders. Why the association? We still don't have the answer. We just know that it's being diagnosed. So, where do we go? We've got to start with the assessment. So we're going to assess that mood, behaviors, thought processes, and speech patterns such as flight of ideas, clang associations, grandiosity, cognitive functioning. So what are we talking about? We're going to be looking for like flight of ideas, looking at continuing flow of accelerated speech with abrupt changes of topic, usually with an understandable association between play on words. We're going to look at clang association, a string of words because they rhyme with the sound without regard of meaning. We've talked about grandiosity, the inflated self-regard of ideas and behaviors. Cognitive function. We see that more impairment in bipolar 1 than in bipolar 2. And it's usually seen in the manic phases. That problem-solving abilities impaired, thinking things through. The earlier we treat, the decreased risk of cognitive impairment. Again, the earlier we treat, the decreased risk of impairment. So, we're going to be looking at the speech pattern. We're going to be looking at the thought content. So these are on page 229. Okay? So pressured speech, what is that? Unnecessarily urgent, fast, rapid, most likely it's going to be loud, incoherent, frequently just talking. It's just going to be rapid. It's going to be under fire talking. That's circumstantial, unnecessary details that kind of derail. It's like going on a long trip of a winding road, but eventually the patient gets to the point of the conversation. Tangential speech, which is loose thoughts, but the person never gets to the point. They lose insight of their point, and they will tell you they've lost their point, and they lost what they were talking about. Loose associations during the conversation. You guys might be talking about traveling, and the person mentioned, I had packed in when we were traveling, the suitcase got lost, and the person said, You know, I had a case that had a 12 pack of beer in it. And you're looking at them going, what? Because you said suitcase, they picked up that word case, which reminded them of a 12 pack of beer they had. Okay? Loose association, where flight of ideas is where a patient talks from topic to topic to topic. Clang association, let me think if I can give you an example. Patient strings a row of words together that have no meaning of any conversation. So, because they like the sound. The cat and the clown and the cat and the clown and the cat and the clown and the cat and the clown clicked away on the clickety click click horse. Because we like the click, the kick sounds. Okay. Grandiosity, we've talked about, that's that inflated self-regard or being rich and famous, superpowers, any of those kind of components. Persecutory delusions. Now, I want to make sure you understand the difference between that and paranoia. So persecutory is more of you're being punished or being spied on. Where paranoia, somebody is out to get you. So what are some of the problems that can be avoided if your manic patient gets proper treatment? Well, first off, you can avoid some suicide attempts, alcohol and drug abuse, marital and work problems, the development of medical and comorbidity issues. Those are some of the big ones that you can be avoiding. I'm sure you can think of a few more. So, self-assessment. These are some things you need to think about because this is one of your most challenging patients that can be presenting to you, especially those that are in a manic phase. Why? Because when a patient is in a manic phase, you're going to see a lot of manipulating, demanding, splitting behaviors your patient will be using. It's going to be challenging not to have countertransference, not to have an emotional response. And you're going to need to be able to check yourself and remind yourself this is not about you. They are having a rough time. They are not going to be able to manage themselves, and so they are going to do what they need to do to try to manage their emotional level, to meet their needs, to meet the neurotransmitters telling them they need to have sex, telling them that they need to move, telling them that they need to use substances, telling them that they need to kill themselves, telling them that they need to be God right now and that they should be able to have their way at this moment. You're going to find yourself needing to set constant limits with them. You're going to need to have frequent staff meetings. You're going to have to tag out your employees because they're going to get exhausted and tired. And you're going to need to figure out how to have your meetings and meet frequently, tag team out, and redirect this patient back and forth so that no one person feels like they're standing alone. Because your patient in a manic phase is going to have so much energy that they're going to wear someone down. And this is a very easy point of time when someone will potentially have countertransference where they will want to shout, yell, name call, and at that patient. Because that patient is capable of pushing somebody's buttons. And you're going to say, they're just doing this deliberately. They're trying to get to me. And the thing is they're God right now. Whether they're God or maybe the devil in their head and the role they're playing and they're famous and they've got superpowers, they're not doing this in a right state of mind. And it's hard to remember that when they're coming at you all the time. So you have to have team meetings, you have to trade out, you have to come up with new strategies, you have to use your medications and allow to keep working with this person and decreasing their stimuli and then redirecting their energy. It's essential. So, continuing to assess, we have to assess for danger to self and others, the need to protect, to provide protections from uninhibited behaviors, the need for hospitalization. We need to assess medical status, because not only the fact of unprotected sex and potential STDs, we're substance abusing. We may be eating very poorly or fried foods, all these things that are going to mess up with the liver, along with other components that may be going on. Coexisting medical conditions that are being not treated or followed through with because they're not going to the doctor. Eating high sugary foods and they have diabetes. And then what is the family's understanding of this disease process? How is the family holding up? What are they doing? How are they doing to help assess, manage, and maintain this person, and being able to report if they're stabilized or they're declining in status, so they're getting the right care. So, nursing diagnosis, what are we working towards? Well, the first one is risk for injury, risk for violence, other directed or self-directed, and ineffective coping. Then we have other things such as low self-esteem, impaired self-concepts, a few other items. So in the acute phase, we're going to be working on preventing injuries. In the continuation phase, we're going to focus on relapse prevention. And in maintenance phase, we're going to limit the severity and the duration of future episodes. So during planning, this is where we're going to work on the acute phase of medical stabilization, maintaining the patient's safety, and self-care needs. Where in the continuation phase, we're going to maintain medication adherence, psychoeducational teaching, and getting those referrals set up. And in the maintenance phase, we're going to work on prevention, relapse prevention. So let's talk about that acute phase just for a little bit. What are we talking about with self-care, maintaining safety? So we're going to be managing those meds. We're making sure that patient's taking those meds, swallowing those meds. Because especially when you're in a euphoric state, you don't want to take those meds. You're God. You don't want to come out of that euphoria. It feels too good. Because I'm going to bring you down, and that's a bummer. You don't want to come down off of that high. And you're going to find every reason you don't need to, or you're going to want to even create your own remedy because, see, you're God. And so you can create your own special concoction to take to make and heal yourself. And that's not an uncommon comment or action that a patient will take, just so you guys are aware of that. That is not uncommon. So, with that being said, we want to make sure our patient's taking those medications and we're reinforcing and educating. We need to decrease the patient's physical activity. So do not be surprised if we're needing to do troponin levels, because this patient is in constant motion. It actually looks like they're having a heart attack. Their troponin levels can be off the scales because they are burning up so much muscles because they are moving. And so with that being said, we are going to need to increase their food and fluid intake because they're in constant motion. And asking them to sit still for a meal may not work. So you may need to have high protein foods and fluids that are finger foods that a patient can walk with and eat with. You need to ensure at least 4 to 6 hours of sleep per night. So if a patient isn't sleeping and we're not getting them down, we may need to have quiet times where we can have them rest during the day just to try to get them to stay off their feet for a period of time. So we may need to intervene in their self-care needs to make sure they're getting met. Seclusion and restraint may be an intervention that is needed depending on how volatile a patient may get. ECT could also be an intervention that may be considered in the acute phase depending on how severe the mania or the depression is. But when we use ECT, we have to be very conscious that the patient can go to the extreme, and if they're in a manic phase, can swing all the way to the depressed phase, or if they're in the depressed phase, can swing all the way over to a mania phase. So, explain, and these are some of the objectives we're going to work on now about the communication with a patient experiencing mania. Describe some of the common medications and distinguish signs of early and severe toxicity of lithium. So, implementation. Depressive episodes. Hospitalization is needed for suicidal, psychotic, and catatonic signs. And again, catatonia is when that patient is basically not physically moving. They're literally almost frozen in place. So they're physically not caring for themselves, they're not eating, they're not moving, and they're basically bedridden. Medication concerns about bringing on a manic phase. Antidepressants can cause a patient to go into mania. So we have to look how to stabilize that mood. That's where we bring in the lithium or an anticonvulsant to try to help stabilize the mood. Hospitalization for mania is usually common. And we have a lot of communication challenges and strategies. So communication approach, this is where you get to have fun. I need you to make sure that you look at table 13-3, which is on page, it's table 13-3. It starts on page 231 to 232. Look at how to intervene with someone with mania, because you're going to be firm but calm in your approach. Short and concise explanations. You've got to be consistent, and you need to hear and act on legitimate complaints, because your patient's going to complain a lot. So you need to hear and act on the legitimate complaints. You need to let go of the nonsense ones. You've got to firmly redirect the energy to a more constructive and appropriate channel. There have been many times when I have given hand and foot massages to a manic bipolar patient just to redirect them out of the environment down to a room to get them off and out of everybody else's space and out of the stimuli, to try to relax them using a few pressure points on the bottom of the feet and hand to just try to de-escalate the situation, because this patient doesn't have control over themselves. And staff members have to consistently set firm limits. Be non-threatening, approach in a neutral manner, and prevent further escalation of the mania. And keep the boundaries safe for all patients, not just that patients, but for everybody, because this is where other patients can get agitated and can actually hit this manic patient, because they can be very intrusive into other people's spaces, and they don't even realize that they're being intrusive. So when we're doing our pharmacological interventions, there's two focuses that we're trying to do. One, decrease the agitation. Two, get the mood stabilized. So we're going to get that lithium carbonate loaded on board. So these are the lithium levels that we have that we really want to work our patients towards. With this lithium level component, I am going to tell you that a lot of times when we hit a 1.5, that is considered a toxic levels. Doctors do like to keep it at like a 1.2 versus a 1.4, just because, especially in the state of Florida, when it gets so hot, it just a little bit of sweating can cause a person to get a little bit nervous. So when we're talking about toxicity versus normal, okay, so let me step back a minute. So lithium is really good to treat symptoms of elation, grandiosity, expansiveness, flight of ideas, irritability, manipulation, and anxiety, okay? But it doesn't help with insomnia, the psychomotor agitation, threatening, assaultive behaviors, distractibility, hypersexuality, paranoia. It doesn't help that half of the mania, okay? It takes 7 to 14 days to get effective blood levels, 7 to 14 days. So this is how you start looking at your signs and symptoms when a patient's complaining of side effects. Because if they just started on the meds and they're complaining of some polyuria and some nausea, I know that it's just normal side effects and that we're not getting into early signs of toxicity, because they haven't been on it long enough, because it needs to be 7 to 14 days to get an effective blood level, okay? But before my patient gets started, I need to know what the BUN and creatinine levels are. I need to know what my patient's electrolytes levels are, and I need to know that their the cardiac system is functioning. So cardiac and kidneys need to be functioning normal, so that in order to take this medication. On top of that, then, normal side effects of this would be some fine hand tremors, some polyuria, some mild thirst, nausea, and some weight gain. That is what I expect to see, and these things should subside within the first 2 weeks. Now, early signs of toxicity, okay, and this would be levels that are below 1.5, would be that nausea and vomiting, diarrhea, some thirst, some polyuria, some lethargy, some slurred speech, and some muscle weakness. Advanced toxicity. Oh, and what would you do on early signs of toxicity? You would be reporting it to the doctor, and at that point in time, the doc will make a decision whether he'd cut the amount, the dosage down versus holding the medicine. Okay? Now, advanced signs of toxicity, at that point in time, you would, as a nurse, hold the dose until you spoke to the doctor, because you're going to be seeing coarse hand tremors, persistent GI upset, you're going to have mental confusion, hyperirritability, EEG, not EKG, EEG changes, and incoordination and sedation. So you're holding the meds at this point and you're sending your patient to the ER, okay? Getting a hold of your doc. Now, if you're in a med-surg hospital with a psych floor, you're probably going to be calling your rapid response team. So the next thing that you're doing is, in your severe toxicity, you're going to have ataxia. And this is a 2 to 2.5 is your blood level. You're going to have severe EEG changes, blurred vision, clonic-tonic movements, seizures, stupor, severe hypoxia, and then eventually you're going to have death secondary to pulmonary, um, what do I want to say? Pulmonary edema. Okay. Now, and also you're going to end up having your kidneys are going to shut down, and you're not going to have any urinary output. And that's the other piece that's going to happen. So, some other issues that you're going to have: long-term use on lithium, you're going to have two issues that will arise that is going to cause it's going to cause hypothyroidism, and it's going to cause renal damage, kidney impairment on long-term use of lithium. This link here, if you want to copy and paste from this, will take you to your ability to see what ataxia looks like. And it's more than just an unsteady gait. It's a wide-based gait. The person goes from side to side when they are walking, and they look like they're climbing a mountain at times, but it is a very unsteady gait that you would see. So, case study. Your patient has mania and has been started on lithium. What patient teaching about the medication should the nurse provide before the patient is discharged? So always, of course, you want to discuss the purpose and the requirements of the lithium, its adverse effects, its toxic effects and complications. So they need to know what their warning signs are, right? The situations where they should contact their physician, that they need to know that their blood is going to be checked and monitored, and usually it's going to be monthly. They need to know the two major long-term risks of lithium, of the hypothyroidism and about the kidneys. And they need to know about their diet, that they need to maintain their salt and fluid intake with no sudden changes, that if they do get nauseated, that they should take their lithium with food and never take it with an antacid or with an antiemetic, because those are salt-based and calcium-based products which can increase their lithium level and cause toxicity. And they can never ever have flagyl with this medication. So if they do get an STD, they need to be very clear to the doc that they take lithium and they cannot be treated with flagyl. So anticonvulsant drugs, these are the top 3 that get treated, that are used to treat bipolar disorder. Valproic acid or valproic or Depakote is used to treat mania and rapid cycling. And usually it's used for those that are not responding to lithium. Again, you have to watch liver. Tegretol, rapid cycling, and for those that are treatment resisted. Also, if a patient has severe paranoia and anger issues, Tegretol seems to be very good. And then Lamictal is the first line, especially those that have the depressed phase of bipolar. But you have to be very watchful for the Stevens-Johnson syndrome. And just to remind you about the Stevens-Johnson, it's that initial rash that occurs. But remember, there's going to be a fever that presents, and that necrosis is happening to anything that has mucosa. The underlying tissue is going to be eaten away. This is life-threatening, and only approximately 20% of the patients who present with Stevens-Johnson survive. Other medications that are used in an acute phase, and it helps with the mania and the motor agitation, is Klonopin and Ativan. And those that present with psychotic and agitated states, we see antipsychotic, Zyprexa, and Risperidol. And sometimes it is also used for the maintenance phase. These are some other antipsychotic second generations that can be pulled and used. And first generations we do see used from time to time is the Thorazine and the inhale loxapine. Other treatments, like I had spoken about earlier, ECT. We use a lot of teamwork and safety. Support groups are essential for this patient. This will help as also with family and health teaching and health promotion. So some of the things also with family we do talk about with them is putting credit card up, monitoring their sleep if they're not sleeping and getting the right amount to call and report, watching their medications and making sure that they're actually being taken, and just making sure they're not being also hoarded for an overdose attempt. Food and fluid intake. It is not recommended when a patient especially has been in a manic phase because we'll hear them, well, I'm feeling much better now. I can go back to work. I'll just go back to work part-time. No, 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 no. When you are not able to recognize that you're being intrusive and making good judgment, going back part-time to work is not a good idea. All it takes is one rude comment or another and you lose your job. So you need to not go back to work until things are all stabilized. So psychotherapy, we're going to be working on that cognitive behavioral therapy and working on interpersonal and social rhythm therapy. So you're working on recognizing your interactions. Work on evaluation outcome criteria, reassessing care plans, and revising care plans as you go through. Because they'll get a little bit better, we're going to now start working on the next goal, the next goal, and the next goal until they're back to functioning. So by the time that they're done, they're able to recognize where they're at, asking the right questions, so they're listening to the feedback of others to help evaluate themselves. So which anticonvulsive medication might be prescribed for a patient with bipolar disorder? Depakote, Klonopin, Zyprexa, Lithobid. If you picked A, Depakote, you are correct. Ms. A, 53, has just been admitted to your unit with bipolar 1 and is in a manic state. What symptom might you expect to see? Catatonia, expression of racing thoughts, low self-esteem and tearfulness, lack of interest in her environment. If you said expression of racing thoughts, you are correct. Other symptoms you would see would be, of course, extreme drive and energy, inflated sense of self-importance, drastic reduction in sleep requirement, excessive talking combined with pressured speech, personal feelings of racing thoughts, distraction of environmental events, and what else? There's so many more. An assessment interview reveals that Mrs. A is an adjunct college professor who has published 2 novels and is working on a 3rd. It was almost inevitable, she says. I grew up in a family of 5 anxious girls with a competitive, ego-driven professional parents. It was hellish. I found an escape in writing stories and putting on plays with my sisters. When I got a scholarship later, I practically ran away to college, where I absolutely lived on coffee, books, and the drama department. Ms. A further describes her childhood, a part of her life she finds particularly troubling. We all had to compete if we wanted attention. Dad played favorites depending on our grades and talents. I was his favorite, but I hated it because it made my mother hate me. How could she compete with her own daughters? Sometimes in high school, I scared myself with how much I just wanted to hurt them both. I decided I would never marry and have kids. Based on her history, which factor can you identify that may have influence on Mrs. A's condition? Biological, psychological, environmental factors, all of the above. If you said D, all of the above, you're correct. Her nuclear family shows signs of biological factors that put her at risk. This was compounded by a more intense psychological, environmental factors of growing up in a dysfunctional household. Mrs. A started on lithium. Discuss what patient teachings about this medication the nurse should provide before the patient is discharged. So what would those things be? Again, her purpose of the lithium, the adverse effects, the toxicity and the complications, when she needs to contact her doctor, the periodic blood tests, the two major risk factors, medications she needs to not take with it, her diet. So which anticonvulsive medication might be prescribed for a patient with bipolar disorder? A. I'm testing you again.